Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today, we are focusing on a rapidly evolving vertical within interventional radiology, the thyroid. For a long time, the management of benign thyroid nodules and goiters was, a pretty binary landscape. It was either watch and wait with endocrinology or it was surgery.
Right, with all the morbidity that comes with it. But that ground has completely shifted.
It really has. IR has claimed a massive stake in this territory.
Yeah.
And we've moved beyond the question of can we treat this to something much more nuanced.
We're in the refinement phase now. It's all about optimization. We're seeing this proliferation of data that forces us to look at our toolkit thermal ablation versus embolization and make decisions based on real biophysics, not just, operator preference.
That's exactly the framework for today.
Yeah.
We have two major papers we're going to break down. First, a 2025 meta-analysis from European Radiology that basically sets up a title fight between radiofrequency ablation and microwave ablation.
This is the debate that's happening in reading rooms everywhere. Is heat just heat, or does the way you deliver it actually change the long-term clinical outcome?
And then for our second paper, we're going to tackle the unablatable, a study from the Journal of Vascular and Interventional Radiology on thyroid artery embolization.
Yeah, for the massive retrosternal goiters that a thermal probe just can't safely reach. This is where IR really shines as, a vascular specialist.
Okay, so let's start with that meta-analysis.
Yeah.
This was a huge undertaking, 9 studies, over 2,500 nodules, pretty evenly split between RFA and MWA.
And the main endpoint they were looking at was the volume reduction ratio, or VRR. Just to be clear for the listeners, these are all benign nodules. The goal here is symptom relief.
Right, and the assumption has always been if you kill the cells, the nodule shrinks. Doesn't matter how you do it.
And the early data here seems to back that up. At 1, 3, and even 6 months, the VRR curves are, they're superimposable, no statistical difference.
Which makes sense, right? You've got the initial inflammation, the body starts clearing debris.
Exactly. It's all just coagulative necrosis at that point.
But, and this is what really caught my eye, the divergence happens at the 12-month mark. All of a sudden, RFA pulls ahead with statistical significance. We're talking an 83.3% volume reduction for RFA versus about 77% for microwave.
And that 6% difference might not sound like a lot, but on a big 50 milliliter nodule, that's a significant amount of residual tissue. So the question is why? Why is the RFA necrosis resorbed more efficiently?
It has to come back to the physics of how the energy is delivered. Microwave is all about power, right? Higher temps, faster ablations.
High power is a double-edged sword. It generates heat incredibly fast. You're seeing temperatures well over 150 degrees Celsius in the core of that ablation zone.
And what does that do to the tissue?
It carbonizes it.
It actually chars it.
Essentially, yes. You create this desiccated, carbonized core, and biologically, that's inert material. It's much harder for the body's cleanup crew, the macrophages, to get in there and break that down compared to the softer coagulative necrosis from RFA.
Which caps out at a lower temperature.
Right. RFA is resistive heating. It rarely gets above 100 and 110 degrees. As the tissue dries out, the impedance goes up, and that naturally limits the temperature spike. It prevents that severe charring.
So it creates a lesion that's more, bioavailable for the immune system to handle over the long term.
That's the theory, and it seems to hold up. Then there's the issue of the margin.
The marginal venous ablation.
This is critical for preventing regrowth. With RFA, because the heat is more controlled, you can work millimeter by millimeter right along the capsule edge, taking out that blood supply.
Whereas with microwave?
Microwave is just more aggressive. It creates this very steep thermal gradient, and if you're working millimeters from the recurrent laryngeal nerve, that forces you to be more conservative.
You have to pull back to create a safety margin.
You pull back, and you end up undertreating the edge of the nodule. You leave a rim of viable tissue.
And speaking of that nerve, the study did find a signal for more voice changes in the microwave group.
It wasn't a massive difference, but it was there, and it's because of that aggressive heating. We call it the overshoot. The thermal energy can just propagate faster than an operator can react. RFA has a built-in feedback loop with the impedance rise. Microwave just keeps driving energy.
This all connects perfectly to what I think is the most practical takeaway from the whole paper: the subgroup analysis on operator experience.
Oh yeah, the learning curve data. This was fascinating. For operators with less than 10 years of experience, RFA outcomes were significantly better than MWA.
But for the veterans, the operators with more than 10 years under their belt.
The results equalized. It really suggests MWA has a much narrower therapeutic window. It's less forgiving.
It's the difference between driving a high-performance track car and your daily driver.
That's a great analogy. The track car's faster, but if you don't know exactly what you're doing, you're going into the wall. RFA is the workhorse. It's safer and more effective for the vast majority of IRs who are building their thyroid practice.
Okay, so that sets the stage for the standard benign nodule. But what about the outliers? I'm talking about the massive multinodular goiters, 150 milliliters.
The patients coming in with stridor can't breathe,
And a lot of these have retrosternal extension, diving down into the chest.
which makes them totally invisible to ultrasound. You can't ablate what you can't see. These patients are traditionally sent for a sternotomy, a massive surgery.
Often in elderly patients who are poor surgical candidates to begin with.
And that's the exact gap that is filled with this study on thyroid artery embolization. They looked at 56 patients, and get this, 84% of them had retrosternal extension.
These are the unablatables.
Precisely.
The technique here is really advanced. It's not a simple embolization.
No, this is high-level microcatheter work. You're coming from the groin, selecting all 4 thyroid arteries, and you have to look for the thyroidea ema artery.
Which they only found in one patient, but you have to look.
You have to. If you miss it, you leave a huge collateral pathway open, and the procedure fails.
Now, a really interesting part of the protocol was the safety break. They didn't just block all 4 arteries.
Right. They made a point to embolize only 2 or 3 of the feeders. You always have to leave at least one artery, and that's to protect the parathyroid glands.
Which share the same blood supply.
They do. If you wipe out the entire vascular bed, you could cause permanent hypoparathyroidism, which is a lifelong complication. Sparing one artery preserves just enough flow to keep them alive while still killing the goiter.
Let's talk about the embolic agent. They used PVA particles, specifically in the 355 to 500 micron range. Why that exact size?
It's all about balancing penetration with non-target risk. If you go too small, say under 300 microns, you risk those particles passing right through the capillary bed into the veins.
And causing a pulmonary embolism.
Or worse, a stroke if they have a PFO. But if you go too big, over 500 microns, you just get a proximal plug. That 355 to 500 micron range seems to be the sweet spot.
And the results were, they were pretty incredible. For single nodules, volume went from about 80 down to 25. That's a 69% reduction.
Which is comparable to RFA, but on these enormous, complex masses. But the number that really matters here is the retraction of the retrosternal part.
It went from about 32 millimeters down to 16. It halved.
That is the difference between tracheal compression and an open airway. The patient-reported quality of life scores, the 5 PRO scores, they plummeted from 155 to 70. These people could breathe and swallow again.
But we have to talk about the physiology of what happens when you infarct that much tissue.
The hormone dump. It's unavoidable. When all those follicles rupture, they release their stored T3 and T4 right into the bloodstream. You get a transient thyrotoxicosis.
How do they manage that?
Aggressively. Beta blockers for symptoms, methimazole to block new hormone production, and this is a real pearl.
The bile acid sequestrant.
Exactly. Thyroid hormone gets reabsorbed in the gut through enterohepatic circulation. Closteramine binds it up in the intestine and helps you clear it from the system much faster.
Now, there's a fascinating subset of patients who were hyperthyroid to begin with.
Yes, and this is where the paradigm could really shift. Of those patients, 86% became euthyroid after the procedure. No more medication.
And crucially, they didn't become hypothyroid, which is what happens with radioactive iodine or surgery.
It's the holy grail. You're killing the hyperfunctioning nodules while preserving enough normal tissue to maintain a euthyroid state. It's really remarkable.
We do have to address the one mortality in MI 2 weeks later.
Yeah, and it really underscores that while the procedure is minimally invasive, the physiological impact is major. That hormone dump puts a huge stress on the heart. These patients need very close cardiac monitoring.
Okay, so let's synthesize these 2 papers. Let's build that decision matrix for the IR listening. Scenario A, a standard symptomatic benign nodule. You're building your practice.
You reach for RFA. It's safer for the nerve. You get better long-term reduction because you avoid carbonization. It's the precision tool.
Okay, scenario B, you're high volume expert. You're comfortable with the tech.
MWA is definitely a viable option. You can leverage that speed, but you have to be hyper aware of that thermal overshoot and accept that your 1-year VRR might be a little less.
And finally, scenario C, the massive retrosternal goiter that surgery has turned down.
That is a clear, unambiguous indication for TAE. Thermal ablation has no role. Embolization is the only way to treat that whole volume, retract the deeper part, and potentially cure their toxicity.
It really just highlights the versatility of our specialty, doesn't it?
It does. We need to be proficient in both. A real thyroid service line isn't just one procedure, it's a whole management strategy.
So a final provocative thought to leave with our listeners. That data for toxic goiters. Do you see a future where embolization actually challenges radioactive iodine as the first-line therapy?
I think the data compels us to have that conversation. It works, but it almost always leads to lifelong hypothyroidism. If we as IRs can offer a precise catheter-based solution that preserves organ function, we should absolutely be pushing for that. It's a higher technical bar, for sure, but the patient outcomes could be so much better.
A challenge for the field, but one worth accepting. That's all for today. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.